Okay. Welcome everyone to this discussion of craniofacial care and FDMAS with Dr. Andrea Burke. This is the third installment in FDMAS Community Connects, a monthly webinar series. I'm Tova Burstein, Community Engagement Director with the FDMAS Alliance, and I'm here with some quick housekeeping before we start. We'll be recording and sharing today's program afterwards for anyone to access via our website. We've collected questions ahead of time via our registration form, but we'll also watch for your questions in the chat on Facebook. And you can test out that feature by chatting us your location right now, where you're watching this program from. It's a great way for us to check and make sure we're on live. I see some attendees, but I'm not seeing any chats yet. Got 2 likes. People maybe are feeling shy today. That's okay. I can see that people are engaging. Okay. Well, we're very glad you're here. At the closeout, we'd really appreciate if you'd complete our 3-minute post-webinar survey, which will help us show our impact and continue to support webinars like this one, and provide feedback for upcoming webinars. And then finally, this program is made possible by our donors, with special thanks to Ionis and Ultragenics and to our Charlie's Angels monthly giving circle for their support of our educational programs. We're committed to keeping this material free, and you can help by making a donation on our website. With that, I'll introduce our speaker. Dr. Andrea Burke is an assistant professor of oral and maxillofacial surgery at the University of Washington in Seattle. She completed a fellowship at the National Institute of Dental and Craniofacial Research, National Institutes of Health, where she worked closely with FDMAS Natural History Study there. Dr. Burke is a member of the FDMAS Alliance Medical Advisory Council and has served on the Oversight Committee for the FDMAS Patient Registry since its inception. We are so grateful to have you here, Dr. Burke. And with that, I will turn it over to you.
Great, thank you, Tova, for that great introduction. I'm gonna just start sharing my screen. Can you see it?
Yes.
Okay, excellent. So, so like Tova mentioned, for those of you who don't know me, I'm Andrea Burke. I'm an oral and maxillofacial surgeon. I currently work at the University of Washington here in Seattle, and I did a clinical research fellowship with Drs. Collins and Boyce at the NIH a few years ago. And today I'll be speaking about craniofacial and dental findings, as well as their implications and treatments. So here are a lot of commonly asked questions from patients and caregivers that I get, just about diagnosis, when and how bone lesions show up, where the most lesions are located in the skeleton, whether or not more will develop, functional problems. And before all of this, Tova sent me what you all asked, which was really extensive, but I did go through the questions and I sort of distilled it into this summary of where I think a lot of your interests lie. And so I hope I can hit on all of these, high points for you and generate some discussion at the end. So without further ado, I'm just going to get into some review of anatomy, which I will be referring to. And the reason for this is that the craniofacial bones are some of the most complex in the skeleton. For instance, there are 7 bones that just make up the orbit, the eye socket alone. So some of these bones that I might mention include the maxilla, which is this yellow bone here in the midface, the mandible in blue, the frontal bone, which is in green up here, the zygoma bone in white, as well as sphenoid bones, which comprise the skull base, in pink over here. So regarding prevalence of disease, monostotic disease is reported to be the most common form of craniofacial FD. However, this is primarily still from case reports, which are doctors writing up one or more of their patients, which makes the data slightly inconclusive. And toward the end of the presentation, I've looked really extensively through the literature, and there have been some groups that have tried to publish a lot of these data sets in combination called meta-analyses, and hopefully we can look at some of those numbers together. But many of the reports never mentioned that the subjects have had complete workups to determine if there were other skeletal abnormalities, endocrine abnormalities, etc. And the most commonly reported locations are the craniofacial bones, femur, and ribs. And here I've just sort of defined monostotic being one bone or region, polyostotic more than one, and then McCune-Albright syndrome, which many of you may be familiar with, has other abnormalities associated with it. So where are most of these lesions located? In monostotic disease, I mentioned, refers to either one bone or one regions of bone. And the reason why we often group the bones together is because the facial skeleton is so complex. So in monofacial disease, the zygomatico-maxillary complex, or the ZMC, which you can see in blue over here in the diagram, is one of the most commonly involved. In polyostotic disease and MAS, where the diagnosis tends to be more extensive, the craniofacial region is involved about 90% of the time, with the anterior or frontal part or the cranial base being involved about 95% of the time. That's this area in green on the bottom. Approximately 84% of affected individuals have jaw lesions in the maxilla or mandible, which is the upper or lower jaws. The upper jaw is more commonly affected, and about 31% of folks have lesions in both their upper and lower jaws. So most craniofacial lesions, particularly in monostotic disease, are actually found incidentally. That means you go to the dentist or the doctor, for instance, maybe you have a routine x-ray or an exam and they notice that something that looks a little bit different. And often asymmetries are overlooked because they may be subtle and it may only become obvious when pointed out. So, some of the signs and symptoms that we mentioned are, include asymmetry, functional changes, which we'll get more into, nasal congestion, epiphora, or overflowing tear ducts, headaches, pain, paresthesias or numbness, and seizures. But the last few of these on this list are quite rare. So a good history and physical exam is essential for diagnosis. And in the facial skeleton, the most common complaints are often asymmetries and expansions, or maybe the feeling that there's a mass or something underneath the skin. Sometimes a biopsy is unnecessary because diagnosis can be made on the basis of history, exam, and x-rays. And as you will see, fibrous dysplasia has a very characteristic appearance on x-rays or CTs. In addition to those sorts of findings, genetic testing, which, overall sending somebody to a geneticist might be somewhat helpful, but you really need to look for the mutation in the affected tissue itself. Lab values, while they could be helpful, if, looking at different endocrine or hormone factors such as growth hormone, they don't always give you the full picture. And then, like we said, sometimes biopsy is necessary. I will say that, the only real way to actually get a diagnosis is through doing a biopsy. Okay, so here are two patients from the NIH that I saw with craniofacial fibrous dysplasia. The patient on the left has McCune-Albright syndrome and growth hormone excess, and the one on the right only had monostotic disease. But they both are presenting with asymmetry, what we call vertical dystopia, or their eyes are not necessarily level. The patient on the left side has some proptosis or bulging of the eye. The angles of the corners of the mouth are not level. You can see the nose is sometimes expanded at the base, and there's often a malocclusion or an asymmetry in the dental area of the teeth. So you can see that in this picture on the right side, where the teeth look a little abnormal and there's a growth. So just so you know, the craniofacial exam, what we're looking at, is really complex. So here on the left side are just some of the components that we're looking at. And, all of these, have been measured and, studied and published and whatnot. And there are some sort of gross normative values that you can get, like for instance, on the right side, showing like horizontal facial thirds or vertical facial fifths. And so just to give you an idea of what we are looking at when we're doing a craniofacial exam. So moving on to imaging. I always used to get asked this question, so I just left this slide in. It's basically about risks of radiation when we're doing this. And, as a dentist and oral maxillofacial surgeon, I'm taking x-rays like multiple times a day, all the time. But this point of this slide is really just to show you that, getting these x-rays is very, very, very small radiation risk. Even getting a head CT, which is the full skeleton, is about 2 to 4 millisieverts. When you compare that to, just daily background radiation, how much you're getting per year, or even just an airplane flight at 0.03 millisieverts, you can see that it's pretty low. The one interesting thing though is that the technetium body scans, you can see just how much radiation it is in comparison to all of the other studies that we do. So here's an example of some plain x-rays. The one on the left is showing fibrous dysplasia, and on the right, no involvement for comparison. And basically, the thing that you see on plain films and fibrous dysplasia is this ground glass appearance, which looks very fuzzy. And here are some dental x-rays, otherwise known as Panorex or panoramic x-rays, which are also helpful in the diagnosis. And it's difficult sometimes to see in the lower jaw, but in this, you can see the arrow on the top showing an area where the sinus might be slightly opacified and the teeth are, sort of splayed out, and that could be representative that there's something else going on. We'd say usually we get one of these x-rays just to monitor or initially, and then we'd probably get either a cone beam CT or a head CT. And the one on the bottom, of course, just showing no involvement for comparison. CT, of course, is the gold standard. Here I've just put in the upper right corner that there's 3 different planes, sagittal, coronal, and axial. So these 2 CT images on the bottom are in the axial plane, so as if we've cut you across your midsection, and we're looking up from your feet at your head. So right and left are opposite. These are considered bone windows, which means that everything on the imaging is appearing white. Air, which is in the sinuses, should be black, and everything else is sort of a shade of gray in between. And what you can see at the fibrous dysplasia affected patient on the left side is that the sinus is obliterated as compared to the unaffected scan on the right side. And you can also appreciate some fibrous dysplasia in the lower jaw by the lower left arrow. And here's an example of monoaesthetic disease on technetium 99 bone scan, which is basically showing an increased metabolic uptake. These scans are really great, but the important thing is just making sure that you're at a center where the radiologists are familiar with reading these, because they can be a little bit tricky to look at. And then I put this image here. This is a PET CT scan, which some of you may have heard of. It's otherwise known as positron emission tomography. And it uses metabolic or biochemical functioning of your tissues and organs And you basically get like a radioactive tracer, which then gets uptaken into the tissues. And this usually uses FDG or a glucose analog to do this. So what we're looking at here is just a bone scan on the left side showing that the ribs are affected with fibrous dysplasia. And you can see that on the right side with this area that's sort of green and red. And the reason why I just mentioned this is because it's becoming more and more popularized, I think, in some of the studies I was reading about as a mechanism for monitoring FD lesions. So looking at craniofacial fibrous dysplasia on CT scan, again, we talked about ground glass, which you can see on this top right imaging. But then going down, you can also have mixed or lytic lesions. And lytic or lucent, which is the image that's on the bottom right, almost appears as if there's an absence of bone or an expansion, but it's black, but it's not quite at the, at air level, but you can see that on the bottom. It looks like there's sort of holes that are punched out of it. And the mixed is sort of in between. But basically, the cortex or the outer part of the bone remains intact. And then sort of the meat of the bone on the inside might be very heterogeneous. And basically, I put this here because the appearance of fibrous dysplasia tends to change over time, with younger people showing more of the ground glass appearance, and then, as one gets older, sort of developing a little bit more heterogeneity of the bone. And you can also develop more sclerotic or more sort of dense areas, more cystic components, etc. So when did most of the lesions present? Well, Hart et al. In 2007 showed that about 90% of lesions were detectable by the age of 10. And basically, most craniofacial fibrous dysplasia lesions are earliest to occur, but can remain silent until some kind of deformity or growth occurs. And that's why many of them are detected incidentally. So 90%, like we said, were detected prior to age 15, and no new craniofacial fibrous dysplasia lesions were reported beyond the age of 10 in this study that was done. So how did the lesions progress? This is an example of a patient at age 5 and then at age 15 below. And what we're looking at is on the upper right, the skull from above, sort of looking into the area where the brain sits, which is the frontal and sphenoid bones. And on this scan, you can see the anterior cranial base has a very ground glass appearance at the age of 5. But then as the patient ages, it starts to become more heterogeneous and more of a mixed pattern. And just for comparison, on the right side is a patient with uninvolved bone. And here again is an example of a patient at age 5 and 15. And what we're looking at here on the CT scan, again, is the anterior cranial base, or sorry, the sinuses in this area. So you can, again, just see the difference how the sinuses are becoming opacified and how it changes in appearance over time from ground glass to mixed. And same patient, this is the lower jaw, looking again at the ground glass, more uniform appearance and how it's changing over time at age 15. So the question, will more lesions develop over time? The answer is likely not. But they can change over time, as you just saw. And certainly the biggest form is that they can expand as far as change goes. And these can show as radiographic changes like we just saw. I would say historically, the most dramatic changes occur in the second decade of life, or sort of in adolescence, pre-pubertal through puberty. I think the misnomer that bone lesions burn out after puberty was something that I was taught when I was training, but is not something that we know from the natural history studies is not necessarily the case. Some can become rapid growing, and this may be concerning for other maybe cystic changes such as an aneurysmal bone cyst. It is extremely rare to transform to malignancy. However, we do know that any kind of hormonal imbalances can sometimes exacerbate the way that bone grows. So here are some of the functional problems that I'll be talking about. And I found this article from back in 2011, where this is one of the few papers that they actually had a patient population where they reported the prevalence of the signs and symptoms within the patient population. And essentially, most were complaining of some kind of facial asymmetry or mass, then followed by those complaining of headache. But you can see here that about 24% of these folks, and this was a otolaryngology clinic or an ENT clinic, so they're going to have a probably abnormal grouping of people with, you know, these findings. So there's a bit of bias here, but about 24% were complaining of some kind of blurred vision, eyelid abnormalities, loss of visual field, diplopia, which is double vision, epiphora, which is tearing of the eyes, and then sinusitis, epistaxis, which is nosebleeds, and hearing loss was documented at 3%. And studies back as far as 1968 showed that the most commonly reported neurologic symptom was vision loss. And I would say because polyostotic fibrous dysplasia has frequent anterior cranial base involvement, you know, it's close to the optic nerve, and there were sporadic case reports of vision loss, you know, back in the early part of the 20th century. And most commonly reported, as we said, was vision loss. So therefore, the assumption was, you know, if there's fibrous dysplasia around the optic nerve, and this could inevitably lead to blindness, therefore, we need to do something about it from a prophylactic standpoint or a preventative standpoint, and optic nerve decompression is necessary. And so here is a face that might be somewhat familiar to you. These are some photos back from Dr. Collins' cohort, and just showing, again, at age around 5 and then 15. These are 3D CT images showing that despite the fact that she has craniofacial fibrous dysplasia over this time period, there have been very little changes to the optic nerve canal, as seen here highlighted by the arrows on the right side. And those circles is where the nerve canal is coming, or sorry, the nerve is coming out of the canal. And we see statistically significant narrowing, but the majority of patients from the NIH cohort actually were shown to have normal eye exams. And that's about 95%. So only 2 of 38 patients from this study in the New England Journal of Medicine in 2002 actually showed that they had an abnormal exam. So therefore, based on this, it was recommended that prophylactic optic nerve decompression is not recommended based on radiographic findings alone, since these did not correlate with vision loss. And, you know, fibrous dysplasia is not a progressive condition which results in inevitable blindness. So just because it's there does not necessarily mean that you need to have surgery. And, you know, speaking as a surgeon, unfortunately, I think a lot of surgeons don't realize that. However, you should, you know, be evaluated by, you know, ophthalmologists or neuro-ophthalmologists routinely. And we'll talk a little bit more about this. And I put this here about optical coherence tomography just because it's a relatively new imaging modality, which many centers are now doing, and it's being recommended to look at the retinal nerve fiber layer thickness. And that's what you can see down here in this image. And I apologize, it's sort of out of proportion, but this is a horizontal tomogram of the optic disc, and the retinal layers are demarcated sort of from the red line down to the green. And basically just looking to see, you know, at the optic cup, which is this little area of invagination here, and looking to see the RNFL, which are, you know, the arrows. I don't know if you can see them in this picture, but it's basically the most superficial layer consisting of the nerve fibers that converge at the optic disc. And basically, you know, how to interpret this, still is being worked up. So meaning that many doctors, despite having this technology, aren't necessarily comfortable interpreting it and incorporating the findings, you know, into using it as a modality to recommend treatment or not. Some studies, I would say, you know, are looking to establish the difference in the rate of thinning in patients with or without optic neuropathy. And some clinicians may distinguish between patients at risk for optic neuropathy and intervene before irreversible damage occurs, but it's not really going to be used at this time as an indication for surgical intervention. So just to talk about fibrous dysplasia and hearing loss, changing gears a little bit, an abnormal tympanogram, which is like an audiogram to test for conduction of the middle ear, is the most common audiologic finding in polyostotic disease. And we know that hearing loss does occur, but it is mostly mild. Sensory neural means that the actual nerve is affected, but in the vast majority of cases, it's considered conductive hearing loss, which is the actual eardrum, or in this case, the bone is affected and is what is causing abnormal hearing. Ear canal cholesteatoma is a very rare complication, but has been reported in subjects who have fibrous dysplasia of the temporal bone. And it basically is an abnormal growth like behind the eardrum and is a result of secondary narrowing of the ear canal, and unfortunately can lead to destruction of bones and hearing loss. So this is just a picture of the external auditory canal in purple, and you can see these ossicles or the inner ear bones. And we know that ear canal narrowing is the most common physical finding in fibrous dysplasia. And about 20% of those in the NIH cohort were found to have some evidence of mild hearing loss. Most patients, as I mentioned, had conductive hearing loss, but about 17% had sensory neural hearing loss due to lesions. And in some reports in the Journal of Otology, they mentioned that there were some patients who had some facial nerve sequelae. So here in this image, I'm just showing on the right side a schematic of the ear bones, which are pictured in blue and blown up here, and just the relationship to the bone. And this is the area of the CT on the left side. And here is an example of a patient with fibrous dysplasia affecting the temporal bone and the ear canal. And you can see just the obliteration of all of those mastoid air cells, or the area on the left side that looks like it's filled with air or is black. So as I mentioned, you know, with hearing loss, there have been some more recent studies. This picture on the right side is just showing a ear canal, which is narrowed. In a mouse study by Ed Schau's group, they found that disrupted bone remodeling led to cochlear overgrowth and hearing loss. And in these mice, they developed fibrous dysplastic lesions, and it looked like they were having conductive hearing loss. In another paper from the laryngoscope back in 2014, they looked at 66 of their patients and basically found that about 29% were complaining of hearing loss, about 3% complained of cholesteatoma, a huge percentage were complaining of headaches. And then in this other paper written by Dr. Boyce, which was in JAMA Otolaryngology, they're showing that hearing loss was identified in 41 ears, which was about 22% of this cohort. And again, the vast majority was found to be conductive hearing loss. However, it was noted that the hearing loss was mild and non-progressive in most of the patients. And just a few words on sinuses and congestion. Basically, the function of your sinuses is really to humidify, filter, and moisturize the air. Sinuses are really just open cavities, and they're thought to just help to make our heads lighter. It also affects the resonance of our voice, and you know, obviously helps us to fight infection. And it's been well documented that the nasal cavity and sinuses are affected in fibrous dysplasia bone. So here is an example of fibrous dysplasia in the maxillary sinus and turbinate on the left side, and on the right side, the ethmoid and sphenoid sinuses, which are a little bit higher up and behind the nose. And I don't know if you can see my arrow, but this on the left side is showing that the sinus on the right is virtually obliterated. That area in the middle that's gray is the turbinate, or the part of the nasal bones on the inner aspect, which are affected. And then the ethmoid and sphenoid sinuses on the right image, just showing that huge expansion in the middle, and obliteration of the sinuses, which should be filled with air and look black. So most nasal congestion is, nasal congestion is the most common paranasal sinus problem in fibrous dysplasia. And I would say that given the amount of congestion that's seen, sinus infections are actually pretty rarely reported, or at least not as much as was previously thought. So now I'm going to change gears to talk a little bit about dentistry and other subspecialties in dentistry. And just for those who are not aware, there's many types of dental specialists. So pediatric dentists obviously treat kids, orthodontists who specialize in dentofacial orthopedics, oral maxillofacial surgeons who can do anything from pulling wisdom teeth to doing major craniofacial surgeries, prosthodontists who I would consider to be sort of specialists in creating prosthesis and full mouth reconstructions, periodontists who oh sorry, I forgot I have pictures here. There's prosthodontists and periodontists who sort of specialize within the gap between bone and teeth, that interface, and infections that can occur or bone loss, and endodontists who are root canal specialists. And dental problems, I would say, because there's often complex comorbidities, a lot of these can be frequently overlooked. And so they can have variable presentations or delayed in diagnoses or treatment. And patients can receive various dental therapies, restorations, root canals, extractions, without necessarily exacerbating fibrous dysplasia lesions. So that means that, if you're told to go have your wisdom teeth out, it is not a big deal. If it's an area of fibrous dysplasia bone, it's actually a nice opportunity that you could get a biopsy without needing to take any real additional bone or doing, a much bigger surgery. But it is safe and does not cause any major sequelae. There have been some reports of increased rate of cavities, and that some patients with fibrous dysplasia in and around the teeth might need or benefit from more frequent hygiene visits, using electric toothbrushes, more fluoride applications, and then of course the risk of osteonecrosis of the jaws, which comes from using bisphosphonates or other disease modifiers such as denosumab or Prolia. So this was from a study that was done in 2003 by Sunday Akintoye and on the NIH cohort, and they basically were showing the following findings: attrition, which is basically just a lot of wear of the teeth. This is showing taurodontism, which basically means that there's an increased size of the pulp chamber, which is that neurovascular bundle that sits in the middle of the teeth and is responsible for causing pain. Here is an example of enamel hypomineralization. So the teeth look a little bit whitish and chalky. You can also get enamel hypoplasia, which is just where the enamel doesn't necessarily form correctly. You can develop displacement of teeth or splaying of the teeth, which might affect crowding, missing teeth, and then of course rotation of teeth. And I would say almost half of the patients from the cohort who were sampled at the time were reporting some kind of dental abnormalities, and about 28% had anomalies within the fibrous dysplasia bone itself. So tooth extraction may be needed in cases where teeth appear to be floating or if they are impacted, as we mentioned. Here's an example of a dental x-ray below on the right, showing some of that. Excuse me, in severe instances, children may require a prosthesis, which needs to be adjusted with growth, particularly if they end up losing some of their teeth. But I would say any of these prostheses are great because they can help to maintain space and improve aesthetics. So orthodontic therapy, this is something that I used to get asked about all the time. I would say a majority of patients who have jaw fibrous dysplasia tend to have some form of malocclusion, which is just a disorganized arrangement of the teeth. And the malocclusion seems to be correlated with growth hormone excess or other endocrinopathies or severity of disease, I would say. And that's really just my own anecdotal experience. My own anecdotal experience also has shown me that teeth tend to move more quickly in fibrous dysplasia involved bone, and that there's a tendency to have more orthodontic relapse, but I don't really have any research data to support this. Often using something like a retainer can help reduce the risk of relapse as well. But currently we can assure patients and families that there's no absolute contraindication for orthodontic treatment in fibrous dysplasia, that it is safe to do, but all parties involved obviously need to be understanding, you know, that occasionally it'll, you know, maybe the teeth might move a little bit more quickly. And then malocclusion, here you can see a clinical photo on the top left and the associated x-ray with the arrows pointing out the fibrous dysplasia in the upper and lower jaws. Basically, the question about whether or not to delay orthodontics until skeletal maturity, it doesn't really seem to be necessary in fibrous dysplasia. So I have gotten that question before. And whether or not to do orthognathic or jaw repositioning surgery in orthodontics, it's also an option for severe malocclusion. And I have another slide on that a little bit later. In this case, though, I would say to potentially hold off on skeletal maturity would be a benefit. Just because in general, doing these sorts of surgeries, you don't want to grow after having them. As far as dental implants go, I would say there's still a lack of literature and long-term data, but there are more and more case reports all the time of dental implants being placed into fibrous dysplasia bone. What we know is that the osseointegration, which is the bone healing at the implant bone interface, might be slower, and that the quality of the bone might be a bit thinner. But in this case of a 32-year-old female with McCune-Albright syndrome, it was noted that there was successful integration and loading of the dental implants. That means when you put the crown on top of them, and that the lesions that she had, which were fibrodysplasia lesions, had not been growing actively for about 3 years at the time of implant placement. And after 5 years, this patient still had successful implants. And this is probably the longest term that I've seen in the literature. But like I said, it's limited, and the risk of implant failure, I would say it's always there, but we just don't have a clear number of what it is in this patient population. Again, I would recommend that for younger people, placing implants after skeletal maturity and once the lesion growth has subsided is probably the best rule of thumb. So as far as medication-related osteonecrosis of the jaws, which was formerly known as bronze or bisphosphonate-related, you know, I would say these first case reports were in 2003 by Marks and in 2004 by Ruggiero. And what is osteonecrosis of the jaws? It basically just means dead or necrotic bone due to loss of a blood supply. And it's defined as exposed bone for greater than 8 weeks with a history of this drug exposure. And case reports have been, you know, seen in bisphosphonates, denosumab, other anti-angiogenic drugs, tyrosine kinase inhibitors, which is another drug class. And we still have a very poor understanding of why it affects the jaws more than other places. I would say current ONJ treatment guidelines stress the need for disease prevention, regular dental exams, professional prophylaxis before beginning treatment with the drugs. Oral hygiene definitely seems to be a factor. You need to be understanding of the risk, and the provider giving you the medication needs to understand the risk. You know, a trauma to the bone, such as in the form of an extraction, an implant, or anything else might put you at higher risk. And I would say in the NIH cohort, when we looked at it, when I was there, it was about 5% prevalence, which is actually a lot higher than the overall population prevalence. So similar to patients who do not experience fibrous dysplasia, but take some of these drugs, the development can be mitigated by using the lowest dose, or maybe increasing the interval necessary to maintain therapeutic effects of some of these drugs. And of course, just using clinical judgment, alternative dosing schedules, although drug holidays haven't really been a proven thing as of yet. So how is craniofacial fibrous dysplasia treated? I would say most big centers have what's called a craniofacial multidisciplinary team, and that can include craniofacial surgeons who come in all different flavors, oral maxillofacial surgeons, plastic surgeons, otolaryngologists, neurosurgeons, oculoplastic surgeons, and then they often, because they're at children's hospitals, tend to have pediatricians, pediatric dentists, orthodontists, but it's also important to have audiologists, speech and language pathologists, sometimes geneticists, psychologists, social workers, and various types of nursing specialties as well. And management is based on the extent, aggressiveness, and clinical behavior of lesions. As far as surgery goes, it will depend, like we've been talking about, on skeletal maturity and age. So many of the lesions can be characterized as quiescent or stable with no growth over a period of time, non-aggressive, which means that the lesion's growing but slowly, or aggressive, which can present with rapid growth, pain, numbness, other sorts of symptoms. Monitoring, observation, and close follow-up are probably the mainstays of treatment, and these can be followed using a good clinical exam, photographs, sensory nerve testing, CT scans, as we mentioned, doing other, audiograms and eye evaluations on a regular basis, medical management, of course, in the form of bone pain, if need be. So what are the real indications for surgery? Biopsy if the diagnosis is questionable, and then of course if there's concern for aggressive growth, atypical or unusual behavior. So if all of a sudden your lower lip and chin goes numb, that would be an indication why we would want to do a biopsy, just to make sure that there's not something more concerning going on. The surgical options, which I'll talk a little bit more about, include contouring, which can be done after growth has stopped. Resection and reconstruction are considered a little bit more radical, but it basically completely will remove the lesion, and can be done particularly if there's concern for other associated diseases or malignancy, such as an aneurysmal bone cyst. Orthognathic surgery, which we just mentioned, which will correct any kind of dental facial asymmetries. Again, there's no documented contraindication for that. However, there is evidence that lesions can regrow after surgery and can even become more aggressive. And the biggest thing is that we don't have a crystal ball and can't predict or prevent regrowth. Surgery is not typically indicated for cosmetic purposes unless there's some kind of psychosocial situation when the child is young. Obviously, if the lesions become quiescent, or if somebody who's over skeletal maturity would like a cosmetic procedure, there might be a small risk for regrowth, but I would say overall is less. And here are some of the outcomes data that we published back in 2016, basically on regrowth and reoperation, noting that it's common, particularly after debulking or recontouring procedures. Less regrowth outcomes were seen when aneurysmal bone cysts and bone biopsies were done as compared to recontouring or shaving procedures, they're sometimes also called. Bone resection and reconstruction with hardware or grafting might result in less regrowth and fewer reoperations, but obviously has increased morbidity. So that means that if you're removing the entire area of affected bone, sure, you'll have less regrowth, but you're going to be left with a much bigger defect of the bone. And on the right side, you can see where we had reported the indications for surgery. And I would say 70% were based off of asymmetry alone. What we did note was that in patients with McCune-Albright syndrome with growth hormone excess, this was noted to be a risk factor for regrowth. And while this might go undiagnosed perioperatively, so looking at these pie charts, you know, on the left side is showing regrowth, which is present in blue in subjects with growth hormone excess as compared to those without growth hormone excess. And while there still was significant regrowth, this was significant in the, you know, comparing growth hormone versus non-growth hormone excess. So this says to surgeons, you know, before you just get happy and operate, maybe you should make sure that there aren't other things going on. And this is, of course, important as a multidisciplinary approach. So here's an example of a patient who I treated many years ago with aggressive fibrous dysplasia. She underwent multiple recontouring procedures over the years. And you can see over the years, facial photographs, which changed over time, as well as CT scans, you know, moving from left to right, also showing changes over time. And this was an aggressive lesion. Here are some intraoral pictures, you know, showing again this palatal expansion on the upper right side and how the patient ended up losing several of her baby teeth. And then after, you know, numerous operations, how that area had healed up on the bottom right side. So we already talked a lot about these surgical considerations, you know, rate of growth, functional disturbances, aesthetics, and then the options, the controversies mainly falling into, you know, prophylactic orbital decompression, the best surgical management, you know, conservative versus radical approaches, surgical options. And here I just put together just the last few slides talking about some of the surgical advances that have been made. So in terms of 3D recontouring, now we do all this virtual surgical planning. So this is showing a picture of a cutting guide and how it was specific for this patient, that screws were placed into the area of fibrous dysplasia. And then basically using those as a guide, they were able to, on the right side, showing how they had basically shaved off all of that fibrous dysplasia bone using the guides. Here's another example of just removing an entire portion of fibrous dysplastic bone that's shown here in green. And what they did was take a split thickness calvarial graft, that's a graft from the skull, and actually used it to recreate the zygoma bone as well as the floor of the eye and the side of the eye socket. Orthognathic surgery that I mentioned, you know, as far as jaw repositioning, here are some photos. This was done intraoperatively, showing the sorts of metal plates and screws that we use. And then for whatever reason, this patient had their hardware removed after 2 years, and you can see that there still is fibrous dysplasia present, but that there was healing and union of the bone. And you can see that here on the CT scan looking from the facial perspective. So basically, the studies that have been shown as far as orthognathic surgery do show that there is long-term stability and osseointegration, which means that the screws, you know, and plates don't necessarily need to come out. Here's an example of a paper that was written back in 2017, just looking at prevalence, and this roughly agrees with many of the previous studies. So they were looking on the bottom aspect at the most commonly involved bones and noting that in both monostotic and polyostotic disease, the maxilla or the upper jaw was the most commonly affected, then followed by the other bones of the midface, including the orbital bones or in and around the eye, the zygoma, which is the cheekbone, as well as the lower jawbone, the mandible. As far as regrowth goes, this was one of the best papers that I found. This is a series published last year by Burke et al. In South Korea, where they actually attempted to quantify tumor growth rate, and they were using this equation, which I put up at the top. But effectively, their conclusions were that the preoperative tumor growth rates were significantly lower in patients who were older than 16 years than those less than 16 years, and that postoperative tumor regrowth rates were significantly greater when a shaving operation was performed, as opposed, or sorry, less than 16 years than at greater than 16 years. And I think this sort of goes along with the whole concept of, you know, waiting for skeletal maturity, which in many young people occurs around the age of 16. So I think this is good evidence to support when subjects should be having surgery to help to prevent against regrowth. And then finally, just looking at some outcomes from some papers that have been written recently. This paper from the Annals of Plastic Surgery, looking at conservative surgery versus more radical surgery, which is like removing that entire segment of bone. And they're basically showing that radical excision compared with limited reduction when, you know, controlling for things like age, length of hospital stay, recurrence, and number of procedures was all found to be significant. So that makes sense. If you're removing the whole segment of bone, you're less likely to need an operation in the future. And then finally, just putting up some of these outcomes data that we haven't not published yet, but that Amanda Conradia and myself had looked at, where we were using registry data to look back at areas of bone that were affected and that were operated on. And so here are just some of the subject characteristics, looking at the various areas that were of the skull that were affected. And, you know, about 42% of this group had surgery, 58% did not have surgery on the craniofacial skeleton. And effectively what we wanted to just look at was quality of life parameters and looking to see whether craniofacial surgery would improve subjects' quality of life. And essentially, there was no significant difference between those who did not have surgery, which is shown in blue, compared to those who did have surgery, shown in orange. And so it was not significantly related to any kind of long-term physical or mental health outcomes. And although the bivariate relationship between the number of surgeries and mental health was not significant, it did suggest somewhat of a positive association. So the bottom line is just taking into account, you know, psychosocial factors before going ahead and doing a major operation on the face and or skull. So, and of course I have to put in a disclaimer that everybody should join the patient registry. So I'm sorry, Tova, for going a little bit over time. Thanks to everybody, but we can have hopefully a nice conversation.
Thank you, Andrea.
I'll stop sharing.
Yeah. You've covered an incredible amount of material in a brief time, and we've gotten lots of comments appreciative of your clarity and the depth you were able to go into. So thank you for that. Some of these questions you touched on, but I do want to make sure the questions that came in, we have a moment to talk about. First, just generally, where should patients seek care? You know, it's really hard to know what kind of doctor should they go to, first of all, but then also, do you have suggestions of like locations? A lot of people have a hard time finding doctors who have seen any cases of FD, never mind just like one or two.
Yeah, well, I mean, it's difficult, right? Because, you know, being a rare disease, it's definitely not something, you know, even at major medical centers, there are going to be, you know, folks who just maybe have like seen like 3 patients in their entire, you know, 20+ year career. So it's really difficult. I think finding somebody who you're comfortable with is probably like the most important thing, but also finding somebody who's willing to learn, you know, from patients and who's learning to, or who's willing to look things up and to not claim to know everything, because I think just having a sense of, you know, this is a, you know, growing area. I mean, even just looking at all of the literature that's been published in the last 5 years, I mean, it's just exploded. So I think having the ability to go back to the most recent, you know, publications and look and see what's out there, what's being recommended, is, you know, the most important thing. So, you know, going to see a surgeon who's, you know, knee-jerk reaction is, you know, you need to have surgery. I would encourage, patients to seek out multiple different opinions if possible, because, if you're sort of scratching your head and wondering, is this the right treatment, then, maybe it's not. So, I mean, to answer your question, like obviously tertiary care centers, which are those major medical centers, which are located in major cities across the country, are probably going to have most experience, or at least have, the most, in terms of their craniofacial team, the most resources, which would be really helpful. And, so knowing sort of the referral pathways to getting into a lot of those centers is important. And most of those groups usually have a nurse or some other such administrator who's in charge of, accepting patients to be seen by the multidisciplinary teams. I will say that maybe one of the advantages of COVID and now doing so much more telehealth is that, you don't physically have to necessarily go to the city where the center is anymore. I think they can do a lot of that stuff through a telemedicine visit now, which might make things a little bit easier. But if you go to websites of various like children's hospitals, for instance, or major medical centers that have craniofacial services, you'll find that there's usually a person, who has an email or something that you can contact. And that's really what I would suggest. And I know as part of the FDMAS Alliance, we were trying to, put together a lot of those teams. For craniofacial, I would say, I know people sort of all over the country, and even if they're not necessarily familiar with FD, they are at least like willing to talk to me about it. So, seeing a lot of those folks is probably fine too. A lot of dentists will like balk at the, at seeing, patients. And I think that's the reason why there's been reports of more like cavities and things like that. It's just because, patients haven't felt as comfortable getting care, or providers haven't been as comfortable providing appropriate care. So
yeah, so actually that's a good plug for if you do have a doctor, a clinician that you see out there that you feel comfortable with, who, is essentially willing to learn alongside you and reach out, then please do suggest them to us so that we might review them and add them to our database.
Yeah.
And I think just my layperson understanding of what your presentation was, Andrea, that you shouldn't delay dental care. There's no reason to put off orthodontics or just normal, like would wisdom teeth fall into that? Just continue
yes. Mm-hmm.
with
yeah,
all
I mean, yeah, just I mean, things like wisdom teeth, orthodontics. I mean, well, orthodontics not so much, but like wisdom teeth, it's considered preventative care.
Mm-hmm.
I mean, most insurance will cover it. And like I said, one of the advantages of taking out wisdom teeth in an area where there's fibrous dysplasia is that you could actually take a biopsy, so you sort of kill two birds with one stone, so to speak. But yeah, I would say there have not been any reports that I have seen, nor have I anecdotally seen anyone who we've taken out their wisdom teeth on and all of a sudden the lesion, starts to take off and grow. Mm-hmm. So I would say, get routine dental care, and it might mean that you need more frequent cleanings, if there's an area of crowding or if there's a area of concern. But definitely get hooked up with a dentist who, feels comfortable seeing you, treating you, and an orthodontist who has an understanding that, the teeth might move a little bit differently in fibrous dysplasia.
Mm-hmm. And then for folks who maybe, they're past that point and they're looking at getting implants or dentures, is there something different that they should consider, or should they also continue?
Yeah, that's a really good question. I mean, as far as, dentures go, there's no contraindications to getting a denture made. If you have, fibrous dysplasia or any other kind of fibroosseous disease. I would say, as far as implants go, it's really a risk-benefit conversation that you need to have with your provider, as you would with any kind of, surgery. It's a lot of money. It's something that you want to, be aware of what's going on up front, just so that you can understand, baseline, if you don't have fibrous dysplasia, there's a risk that implants can fail. So not really having any numbers to work with, just trying to ascertain whether or not you're a good candidate or not with your provider, and then, having the provider sort of work with you. Maybe the implant needs to be a little bit longer or a little bit fatter, to gain more surface area if the bone is a bit softer. Just taking things like that into consideration are important. But I think as long as all parties understand the risks associated and are still willing to undergo the procedure, it's, mutually beneficial.
So then, and I hope you've got a couple more minutes for try to squeeze a few more questions in here.
Yeah, of course.
So then, moving then to other functional concerns, you said that it's a very low risk of losing hearing or vision, and really watchful waiting is the recommended way to go. Can you reiterate, and that it's, again, very rare, because there were several questions. Am I going to go blind? Am I going to lose my hearing? It's very rare. What tests should people be asking about for those?
Yeah, I mean, I would say those, from everything I've ever seen or everything I've ever read, those people who are presenting with acute symptoms of, you wake up one day and your eye is blurry, or, things like that, you should have a high suspicion that there is something else going on. And it's not just like run-of-the-mill fibrous dysplasia, because that's not really been reported to be the natural history of the disease. The natural history, if you are monitoring as you are going and staying on top of things and have a physician you're comfortable with who's staying on top of things, you should be able to nip things in the bud, to ensure that you don't end up with blindness. Now, if you develop like an aneurysmal bone cyst or some kind of other like cystic, disease within the bone, those are really rare instances, but they've been reported. And so that's why I say, if all of a sudden you start to experience swelling, in and around the eye, it's something that I would not wait to get checked on. I would be seen right away for something like that. But overall, we know that the risk of blindness is, very rare. There is a appreciable risk of blindness when we do operate in and around the eye. It's not zero. I know for trauma, what we're doing, we usually tell people it's about like 2 patients out of like 100. So it's there, but I would say, just again, having that important risk versus benefits conversation with the provider, and closely monitoring things is the recommended treatment for most of these functional issues.
And then, it had, I think aesthetics also, people often really want to have surgery for aesthetic reasons. And my understanding had always been that, we advise against it because of regrowth is, it's a big problem. But what I heard today was that when bone lesions, when the growth slows down, that's where you're saying maybe over the age of 16, where we see less activity in the bone lesion, that it might be okay. Is that a fair read?
I mean, that's basically what that paper from South Korea is saying. I think, I would take a lot of these papers with a grain of salt, but that was like the only one that I could find that actually, had some data, because we've always been told, wait for things to burn out, then they'll be fine, and then you can operate. And I still think for the vast majority of folks that probably remains true. But I also have met many people who have had, growth of lesions spontaneously, well into their 50s or, older. So I would say, obviously, everybody needs to be taken on an individual basis. It's nice to have a benchmark so that you could kind of say, okay, well, I know that, after I turn 16, there's a less of a likelihood for it to recur if we're considering doing something like orthognathic surgery or a, you know, shaving procedure, for instance. You know, but it's still so difficult because, you know, I've seen all permutations of different things happen. You know, we don't think it will regrow and then it does regrow, or some, you know, times you almost activate something when you know, do a big procedure. So it's really hard to know for sure. And I think we just need more long-term data. I think it's just that now a lot of the case reports that are out there, people are finally starting to report these things.
And it does sound like consulting with an endocrinologist, you mentioned that growth hormone and hormone imbalances can make a big factor in that.
Yeah, I think that's a really important point, is that, you know, as surgeons, making sure that you're working in a multidisciplinary team to help manage. And, you know, some people might present with a mass and not be aware that they have a growth hormone excess, you know, until they have labs drawn. You know, it's sort of just like a very like silent thing. And I think just having a healthy suspicion for things and referring to the appropriate folks, you know, is really important. I know I get referred people here in Seattle for fibrous dysplasia, and I've sent pretty much all of them to endocrine or some other specialists, you know, just to do like a full workup if we have suspicion that there's, you know, more than just the one jaw lesion. So it's hard for surgeons, I think, to look outside of the box sometimes when you're so honed in on, you know, this person was referred to me, they have a mass, I have a scalpel, I want to operate. But, you know, making sure that you're going into it, and, you know, for patients too, understanding that if there is anything else going on, you want to make sure that it's medically controlled before having surgery.
Thank you. And I have one more question here, a big one. You know, several people asking about pain, in particular the trigeminal nerve. What's your experience with advising folks on pain?
Well, so, I mean, trigeminal neuralgia is different than the bone pain that we see in a lot of fibrous dysplasia lesions. So I'm not sure if people are referring to like bone pain associated with FD or trigeminal nerve pain per se. But I will say, I mean, there's trigeminal neuralgia, which, you know, I would most of the time is treated by different groups. Sometimes it can be oral and maxillofacial surgeons. Sometimes it's neurologists. I refer a lot of people with atypical facial pain to neurology. In some instances, you can do workups like MRIs if there's an area of stenosis or narrowing, which might be related to fibrous dysplasia. Sometimes they can make those areas bigger, similar to an optic nerve decompression. Obviously, understanding that a sensory nerve, you know, or even a motor nerve for that matter, you know, if you do damage to it, you kind of end up with nerve damage. So working in and around nerves in general is pretty tricky. But I would say that, you know, having somebody look to see, like, is decompression an option? Is it something that can be medically treated? There's medications like gabapentin, like Lyrica, that are more specific, like targets to nerve pain. One thing that we often do, just because we're dentists too, is we can give diagnostic nerve blocks. So if we think that it is a specific nerve, we can give you a shot of Novocaine in the area where the nerve is bothering you to just assess, you know, which part of the nerve is being affected and, you know, causing pain, for instance. So I would say getting an appropriate workup to make sure that you're dealing with the right nerve, because, you know, nerve pain, particularly in the head and neck region, it can refer to all different areas. And so it's very difficult to tease out exactly what's going on. But trigeminal nerve pain, you know, can occur in the lower jaw, in the upper jaw, both. It can occur in the forehead. You have 3 branches of the trigeminal nerve. You know, the bone pain that's associated more with FD, for instance, you know, in many cases responsible to things like bisphosphonates or denosumab, so or Prolia. So it's I think trying to find a provider who's willing to work with you to tease out exactly what kind of pain it is going to be useful. And then, you know, understanding that it's not going to get better overnight. There's not some magic bullet that's going to fix it. And that you might have to try multiple different modalities before you find one that works for you. And, you know, surgery, while it might be an option, you know, there is not without risks.
Thank you so much. And I do also want to refer, last month we had a complete discussion of pain and fibrous dysplasia, McCune-Albright syndrome. So for folks who have more questions about that, they should definitely check out that which goes into a more general of what Andrea was talking about with FD pain. That is going to be all we're going to take for right now. I'm going to put 2 links in our chat here. The first is the FDMAS treatment guidelines, a link to the FDMAS treatment guidelines published in 2019. Our medical advisory council across the board, when we asked what we could do to improve patient care, they really wanted to make sure that people had access and knew that this existed. And then the other link is going to be the post survey for this webinar. Thank you so much to Dr. Burke for your dedication to this community through the registry and the patients, and to each of you for participating. We're so grateful. We're also grateful to our donors who've made this possible, including Ionis, Ultragenics, and our Charlie's Angels Giving Circle. I'm going to post that webinar survey, and we really would appreciate if you took a moment to fill it out and give us your feedback. And our next webinar is going to be October 12th, where we're going to talk about more general surgical management of FD. Thank you so much, Andrea. Again, thank you. I'm so grateful.
Yeah, my pleasure.
And be well, everybody. Okay, now we're done being live and we're done recording. Sorry.